Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello everyone, it's Susan Kaufman here. I'm with Attitude Magazine and you are listening to Attitude's ADHD Experts. One of the most difficult aspects of attention deficit disorder is making sense of the many overlapping conditions and the symptoms of those conditions. We are really pleased to welcome back Dr. William Dodson, who's going to join us to discuss mood disorders and depression, especially as these conditions coexist with attention deficit disorder in both adults and children. Some of the topics Dr. Dodson will address today will include how to identify comorbid mood disorders and depression, how to separate it out from ADHD and other symptoms, why there's really no such thing as a minor depression. Every depression is a major one, and as always, he won't be addressing specific medical advice for an individual, but he will be happy to give an overview of the kinds of medications that are generally used in treating various aspects of depression and mood disorders. Let me just remind you that he's a board-certified adult psychiatrist. He's specialized for almost 30 years in adult ADHD. He's in private practice in Denver, Colorado, where he is a life fellow of the American Psychiatric Association. Dr. Dodson, thank you so much for joining us today.
Thank you for inviting me. People who have an ADHD nervous system are thought of as having won the negative genetic lottery, in that in 70% of cases, they have not only ADHD, but another major psychiatric condition. In fact, the majority, 57% of people, will have two or more additional conditions along with their ADHD. Depression itself is very common at any one time, over any one-year period. 7.6% of Americans will meet all the diagnostic criteria for major depression. For people with ADHD, it's much higher. It's 18.7%. In other words, 2.5 times more frequent among people with ADHD. So very often the question is not whether I have one condition or the other. It's usually that people have both. Unfortunately, ADHD is usually the condition that's missed. Very few adult psychiatrists in the United States have any training at all with ADHD, and it's just not something that comes on their radar screen. They just don't think of it. Whenever we talk about coexisting, or the technical term is comorbid conditions, we need to be clear that one does not cause the other. You've got two separate conditions, each of which requires its own separate treatment. The question is often which one do you address first? And usually the physician takes his lead from the patient. If the patient comes in and says, it's the depression that's just really wiping me out, they're going to address the depression first. That only makes sense. So what is a mood disorder? Technically, to a psychiatrist, they're going to be called affective disorders. And what that means is it's strictly a disorder of the level or intensity of moods. The moods in a mood disorder are universal. Everybody's had them at some time in their life. What makes them abnormal, what makes them a diagnosis, is three other factors. One is the moods have taken on a life of their own, separate from the events of the person's life. In other words, there's no cause or trigger. The person just gets depressed for no apparent reason. People will try and look around to find some cause for it, but usually there's nothing out there certainly nothing that would cause the depth of impairment that you usually see with depression. The second thing is the change is gradual. People slowly go into a depression over a period of weeks to months. Usually we're used to something happening in our mood from that trigger is instantaneous, and it matches the nature of the trigger. You don't have that in depression. Again, gradual onset, and there's no trigger to match. And the third thing is nothing you do helps. It's outside of people's conscious will and control. By definition, in the United States with the Diagnostic and Statistical Manual, these symptoms have to be present uninterrupted for at least 2 weeks. And this was put in there specifically for people with ADHD. People with ADHD have very strong, passionate lives. Their moods change a lot, but the moods rarely last more than a couple of hours. So really the concept I'm trying to get across is that in our brain we have a thermostat for our moods. Some days are better than others for no particular reason, but it's within a fairly narrow range. If the bottom end of the thermostat breaks and mood and energy level just keep on going down, we call that a depression. If the top end fails, and people just get extremely energetic and grandiose and expansive, we call that a mania. If both fail, we call it now bipolar disorder. The old name was manic depression. While manic depression is quite uncommon, only about 1% of the population in the United States has bipolar disorder, the reverse is not true. 40% of people with bipolar have ADHD. So it's a very common comorbidity in people who have bipolar. So what are the diagnostic criteria for depression? Most people use the word blue, down in the dumps, that sort of thing. And indeed, that's the first listed criteria in the diagnostic and statistical manual. It's important to note, though, that only about 60% of people with depression actually report any sadness. So you don't have to be sad to be depressed. What is really the hallmark of the condition is a marked inability to experience pleasure from things that used to be pleasurable. Life just feels empty just because it doesn't feel good. Nothing is interesting. Nothing is engaging. It's sort of, why bother to get engaged with something if it's not going to make me feel better. People lose weight because their appetite goes way down. Adolescents, though, tend to start eating everything in sight. So adolescents are always a bit different from everybody else. Most people have disrupted sleep. And you can see it in two ways. One is they have trouble falling asleep. But once they do fall asleep, they'll spend 12, 13 hours in bed asleep. They just have no energy. Everything slows down. They think more slowly. They move more slowly. And actually, the most common emotional symptom in the syndrome of depression is irritability. About 95% of people report that they are exceedingly, but uncharacteristically, irritable. Little things get under their skin, and they have explosive outbursts of irritability. There's loss of energy and motivation, feelings of worthlessness or guilt, decreased memory and concentration. And this is something that can really make the problems with memory and concentration of ADHD significantly worse. It's also why in the elderly, depression is referred to as pseudo-dementia or false dementia, because depressed elderly people look like they're sliding into a dementia. And then, of course, recurrent thoughts of death or suicide. We have to contrast this with what you'll also hear called a reactive depression. What we mean by this is bad things are happening and you feel bad or sad in response. It's important to note this is normal. This is the way it's supposed to be. If there's a clear trigger, you respond to that trigger with appropriate emotions. The other thing is that when things get better, these depressive-like feelings and impairments go away. It's bound to the situation. It is hard, however, to really distinguish depression from the frustration and demoralization of having untreated ADHD. People just say, why try? Why engage in anything if I put out this huge amount of effort without any payback? The other thing that's standing in that overlap between depression and ADHD is what traditionally is called rejection-sensitive dysphoria. Again, terrible technical name, but what it means is that just about everybody who has an ADHD nervous system is exquisitely sensitive, vulnerable to the perception that someone else has withdrawn their love, approval, or respect, or that they themselves haven't met their own standards. And this, again, is a very sudden, almost catastrophic, overwhelming emotional pain. For 60 years, rejection-sensitive dysphoria was the hallmark symptom of what a shrink would call an atypical or non-typical depression. Now there's the growing recognition that the reason it wasn't a typical depression was that it wasn't a depression at all. It was the emotional component of ADHD, and that because it's triggered, it matches the perception of the trigger, and it's an instantaneous mood shift. It's a normal mood in every way except its intensity and how impairing and wounding it is. Reactive depressions don't really respond to medication. They're just a part of life, and it's what they do respond to is going out there and putting things right, making your life better. Counseling, however, can certainly make that process go faster, helps you organize and get things done. As Susan pointed out, we started off with the notion of major depression with the idea that we might find minor depression, and we never have. The World Health Organization lists depressive mood disorders as the third most common cause of chronic disability in the world. This is more than being sad, blue, down in the dumps. This affects every aspect of a person's life and really makes life not worth living. Half of all depressive cases are rated both by the patient and by the clinician as being severe to extreme. So what do you do about a biologic, genetic type depression? First thing is antidepressant medications. But that's not the whole story. When people get depressed, they think differently. There's a tremendous amount of futility. Again, they've tried to lift their mood, doesn't work, and so they say, I don't have the energy to do this, and why bother? Nothing's going to work. They have a sense of personal fragility, that anything's going to overwhelm them, they can't cope. And so they withdraw from all the stimulation of the world. And again, it's sort of the classic, the half-empty glass. People tend to look entirely at the negative and think only of the negative outcomes of their lives and completely lose contact with that healthy self. And so that's what cognitive therapy is helping people recognize that they're thinking differently and try and get back to what they were like before they were depressed. And of course, the combination of medication and cognitive therapy works by far the best. So we have 7 different classes of antidepressant medications in there. Which one's best? Well, they're all pretty much the same in terms of their response rate. About 70% of people are going to respond to whichever one the doc pulls off the shelf to try. They all work about equally well. The effect size, in other words, how well does this treatment work as compared to all the others you might have chosen, for all antidepressants is about 0.7, which is moderately effective. Most effect sizes go between 0.4 and 1, with 1 being very robust. Consequently, the choice of which antidepressant to choose is usually governed by tolerability. People will not take a medication that they can't tolerate, or worse still, puts on weight. Cost, insurance coverage, and associated symptoms. By associated symptoms, some docs will try to choose their antidepressant medication by symptom cluster. What is there along with the depression? So most clinicians, if they have somebody who's depressed, but they also have a lot of anxiety, they're going to reach for an SSRI class, serotonin-specific reuptake inhibitor. If the person has depression but is very lethargic, they're going to use one of the more activating antidepressants such as bupropion or venlafaxine. People who have depression plus pain will very often go with duloxetine or Cymbalta, which has a full FDA indication for treating several pain conditions. Depression plus cognitive decline. This new medication, which I can't pronounce under the name of Brintellix, is a good antidepressant, and one of the things that's very intriguing in a area of tremendous research right now is that the reversal of cognitive decline happens whether or not the person's depression responds. Depression with a history of mania, somebody's going to go to the bipolar medications such as Latuda or lithium. Unfortunately, when you look in the research literature, there's very little to support this pattern of practice, but I hope I do this just to say this might be how your doc will choose one over the other. There's always a question of who gets offered a medication in the first place. Multiples of studies have found that the determining factor is not something rational, it's the attitude of the individual physician. If a doc thinks that they don't like mental health conditions, they don't like people who present them with stuff that make them uncomfortable, if they say, psych meds are overprescribed, they are very unlikely to prescribe an antidepressant. On the other end of the spectrum, there's the physician who has seen people, hundreds of people, get much better with an antidepressant, or very commonly, they'll have either personally or had a family member get tremendous benefit from an antidepressant. Then the prescription of an antidepressant medication is very likely. So what that means is that if your physician is of the first type and they don't offer at least a discussion of what an antidepressant has to offer, you need to look further. You need to push that doc or look to somebody else. That's really, really hard for somebody who's depressed, hopeless, doesn't have any energy, is futile, it's not going to do any good. And so that's where concerned, significant others are vital. Remember that people with ADHD, with depression, have a hard time getting moving. And so you, as the non-depressed person, may have to be the one that really is the motive force to get things done. So what can you expect from an antidepressant? 70% of people get a good response to practically any antidepressant. If you, in that 30% who don't, you try another class. Only about half of those who get a response, however, get full remission. They're better, but they're not back to their old jolly selves. So for 30 years, we have used other agents, which we call augmenting agents, which are not antidepressant in and of themselves, but will boost a partial response into full response. Interesting enough, one of the most common augmenting agents in the United States are the ADHD stimulants. I didn't list them here because there are a couple of new studies to show that really what happened was it wasn't the depression getting better, it's that the doc missed the ADHD completely, and the improvement comes from treating ADHD. But the other ones are Abilify, thyroid hormone, lithium, or just adding on a second antidepressant. And there are things for and against all four of those options. You have to have a long-term look at this. Antidepressants take their own sweet time to work. For the first 10 days to 2 weeks, all you're going to see is side effects, not much in the way of benefits. At about 2 weeks, you see two things that don't happen anymore, so you need to be vigilant and looking for them. What happens is that the irritability really calms down, and the crying spells, if they were there, dry up. Person says, gee whiz, you know, I used to have 2 or 3 crying spells a day, and I haven't had a single one for the last 3 or 4 days. That starts the clock, and it takes another 8 weeks from there to get full remission from the impairments and symptoms of depression. So how long do you stay on an antidepressant? Multiple studies have shown that if you get that full remission, but you stop the medication in anything short of 9 months, 75% of people go right back to the full depressive syndrome they started from. If, on the other hand, you go out 12 months and stop, only about 5% of people relapse. So there's something magical about going out at least a year. When you do stop, don't stop suddenly. Again, any medication that works in the brain, not a good idea to stop it suddenly. Taper off after you've spoken with your doctor about it. Also be prepared for the fact that 85% of people who get one depressive episode will continue to have depressive episodes for the rest of their lives, and so will end up going on medication several times during a lifetime. So at this point, I'll open up, see if people have any questions.
Thanks so much. That was a great overview. Maybe we could start with some diagnosis questions. I think there are a number of people who that might be a way to start, because I know it's always it can be challenging for people who have multiple conditions. One person asks, I think this is a good question, how do you distinguish between, what are the distinguishing features between ADHD and depression?
ADHD is a changing condition. It's what we call consistent inconsistency. People are inconsistent, very changeable, but in a very predictable way. So people with ADHD are very much caught in the now. It's what's happening now, and they are very responsive to now. The other thing is that with ADHD, people with ADHD are very passionate, intense people, but the moods are changing, and there are long periods of time when they feel just fine, when things are going well. So it's that changeability and the tie, the very clear tie to what's going on right now. Depression, on the other hand, is a constant condition. It has a very slow, insidious onset, and the recovery from it is, again, very slow and over a period of 2, maybe even 3 months. And it's constant. It's uninterrupted. There are no periods in which you feel like yourself anymore. So usually it's that pattern of symptoms. ADHD is triggered, immediate, intense, very much matching what's going on right now, whereas depression has a life of its own, pretty much unchanging no matter what happens or what you do.
Okay, that's really helpful, especially for the whole concept of euphoria and mood swings that ADHD people are known for, but yet you're saying that those are taking place within a short time frame as opposed to in a steady state. We have one person here, Sandra, and there are other people with this same issue who's been diagnosed with depression for years and had very difficult time treating it, and she's beginning to think now, very later in life, she's gotten an ADHD diagnosis and is wondering whether the question of whether one can have a primary condition versus a secondary condition, might she actually have had ADHD primarily, and is there a reason to treat? Does deciding that something's primary or secondary help define treatment?
The answer is no. Primary versus secondary, cause versus trigger versus cause, and stuff like that, that just doesn't work out. You, again, won the negative lottery. You've got 2 conditions, each of which has a completely separate treatment, and they're going to respond separately. Again, the problem is usually that the average clinician doesn't think of the very existence of ADHD. Most American psychiatrists are going to interpret everything they see and hear in terms of a mood disorder. Virtually always, when I see a patient for the first time, they have a very long history of having tried multiple antidepressants, when really sometimes the only diagnosis was ADHD. That was the last paper I published.
It's interesting. Yeah, that's exactly what Sandra. Sorry.
Yeah, the doc isn't going to think of it, and also be prepared that when you go back in and talk to your doc, I think I've got ADHD, be prepared for them to tell you that you don't. There's a real resistance among the majority of American psychiatrists about even considering something that might be ADHD.
Wow.
Be
Okay.
persistent.
Okay. In terms of the mood swings, a number of the people who are taking part in the webinar have posted that they live with tremendous irritability that's very difficult for the people around them to live with. Can this be part of ADHD, or is that more commonly related to the depression, the mood disorders? How do mood swings fit into the picture?
It's very difficult to tease apart. Usually the problem with ADHD is that most people go through right at the very tethered end of their rope. They constantly are just about to be completely overwhelmed. They're exhausted, and when something goes wrong, somebody puts something extra on their plate, they overreact. They get mad. And usually it's that they don't see it coming. And that's the whole definition of impulsivity. We speak or act before we think. And that's what happens with people with ADHD. There isn't that 2-second lag where we can say, okay, I'm going to lash out. I really don't want to do that. I'll do something else with it. The person with ADHD sees what they're thinking and feeling in the same way everybody else does. It's already out there, completely raw and unmodified. The other thing that you very commonly see is, again, a triggered outburst due to the perception that somebody has been critical or rejecting. Rejection-sensitive dysphoria is expressed in one of two ways. If all of that emotion is turned inward, they will meet every diagnostic criteria for major depression, but it's clearly triggered. A person with ADHD will say, yeah, my moods are all over the place, but I can see the trigger every single time. And so they can either internalize it and look depressed, or they can externalize it in a rage at the person or situation that wounded them so severely. But again, you see the trigger, it passes fairly quickly. It doesn't last 2 weeks the way a major depressive mood shift is required to do.
Wow, that's interesting. So that's really the hallmark difference between ADHD
Right.
and is that the timing of these symptoms. Okay.
And the trigger. ADHD is triggered.
Right. Okay. Whereas a depressive state can just come over you and takes place over weeks and weeks. All right. Moving on a little bit to medication. People are wondering whether taking ADD medication can help create or exacerbate anxiety or depression. Well-chosen and well-dosed stimulant medication usually improve the anxiety rather than made it worse. So that's not a reason not to use a stimulant medication. Again, just to be a little bit more cautious if the person has a lot of anxiety as well. Again, the rule is that if you have the right molecule at the right dose, you shouldn't have side effects. Or if they are there, it's usually, almost always, that the dose is just a pinch too high. Okay. What about complementary and herbal treatments, specifically St. John's wort? St. John's wort had a real popularity about 12 to 15 years ago. It was thought to work because it's a monoamine oxidase inhibitor, very weak, but that's basically the only chemical activity that you could find. And monoamine oxidase inhibitors were the very first antidepressants back in the 1960s, and they're the ones that if you look on the back of practically any over-the-counter medication, it says, don't take this if you're taking a monoamine oxidase inhibitor. In blinded studies where neither the patient nor the clinician knew whether the person was taking St. John's wort or a placebo, it didn't separate from placebo. You couldn't tell that there was anything there. So right now, there's no objective evidence that St. John's wort works. Okay. Okay, yeah. And then similarly, on the nutrition side, that often comes up, and I see a couple of questions here just to move, and that's not really your topic, but do you have any comments on nutrition for either ADHD or depression?
Yeah. A third of the human race the first thing they're going to consider when they're not feeling well is, what am I eating? Am I eating well? Am I eating a balanced diet? And again, most people do feel better if they aren't eating at McDonald's every day. You do need a good balanced diet. But feeling better when you eat a balanced diet and treating depression or ADHD are two different things. There really is no objective evidence that what you eat has any effect either on mood disorders or on ADHD. And again, people took these preferences very seriously. There are more than 60 double-blind controlled studies on what you eat and ADHD all by itself. And what they found was no detectable evidence. Not a single study found any detectable evidence, which again is a disappointment for a lot of people. And again, if you want to change your diet, go right ahead. It's certainly not going to harm you. And again, in just a general way, you'll probably feel a lot better.
Okay. Just to cover back the herbal supplements thing, there is a person here who says she's used 5-HTP and had great results. So is that something that, I guess that's for depression?
Yes, it's a serotonin precursor. It's designed, the idea is that if you don't have enough serotonin, you give it the molecule that gets made into serotonin. Again, all the literature that supports it are what we call open label. And so consequently, everybody knows what you're taking, what dose you're taking, and so those are very highly susceptible to placebo response. When you look at blinded studies where people don't know, it just doesn't separate from placebo. Same with SAMe, which is also marketed, as a health food and stuff like that. There's just no objective evidence that it's beneficial. It won't hurt you. There's just no evidence that it'll help you.
Okay. Coming back to the relationship between ADD and anxiety and depression, what's the statistical correlation between, I know that anxiety disorders are quite common in those diagnosed with ADHD. Is that also the case for general depression as opposed to bipolar disease?
I think that's on the first slide.
Oh, sorry.
18.7% of people with ADHD will have a depressive episode this year.
Got it.
Sometime during this 12 months.
Wow.
So it's about 2.5 times the risk that you'd see in the general population.
Okay. And again, there are numbers of questions about the relationship between stimulant medication and depression. Can the stimulants hide the evidence of depression? Can they affect the depression? Can they cause the depression? Are all questions that people have asked.
Again, the two conditions are quite separate.
Okay.
When the stimulants first came out and were generally available back in the 1920s and 30s, they were tried extensively because, again, when you look at somebody who's depressed, they don't have any energy. And they were used, and while they did sort of rev people up, it didn't change the depression at all. There's been two recent studies looking at the stimulants as augmenting agents, and they were very careful in the study to make sure the people had just depression, that they didn't have ADHD. And what they found was the stimulants had no effect. Okay. They didn't make the depression worse. They didn't augment an antidepressant. They didn't make it better. They just had no effect. So again, probably the tradition of using stimulants as an augmenting agent is that the doctor just missed the ADHD diagnosis entirely.
Okay, similarly, we do have someone here who was treated with an antidepressant that looks like is bupropion, with the thought that it would also help ADHD. Does that make sense? Can Wellbutrin?
Yes, it does.
Okay.
The medication Wellbutrin is actually, the molecule is made from amphetamine. And usually the people who get a positive benefit from Wellbutrin are people from Northern Germanic Scandinavian backgrounds. It seems that they have an enzyme that in metabolizing bupropion, one of the intermediate steps is probably just simple amphetamine. And that's probably why it works. The studies that have been done on it show that the dose has to be significantly higher than antidepressant dosages, somewhere around the 400 to 450 milligram per day range, and that the improvement can basically happens very gradually, again, over a period of about 8 weeks. Yes, there is some significant double-blind research on Wellbutrin. All the other medications that do have a literature showed detectable effects, but not clinically significant effects. For instance, there are 6 studies on venlafaxine, which is marketed under the name Effexor. Half the studies didn't detect anything. The other 3 had an effect size of 0.4, which is barely but consistently detectable. So it's not something that either the patient or the clinician would even notice. So again, there's a great deal of difference between something that's statistically significant and something that is clinically significant.
Mm-hmm. Okay. In both depression and attention deficit disorder, difficulty sleeping seems to be a common symptom, and a number of people are asking about that, about the difficulty sleeping and whether how they might be treated in people who have either ADHD or depression or both.
The sleep disturbances of ADHD is one of the major unrecognized, unresearched area of ADHD. Somewhere between 85 and 90% of people with ADHD are going to have impairing difficulty with initiating and maintaining sleep. And I know that if I get into bed at a reasonable hour, I'm not going to be able to turn my brain and body off. Toss, turn, fidget, can't get comfortable, and my thoughts bounce from one concern and worry to another. The average length of time that a person lies there just absolutely wired with their thoughts bouncing around is 2 hours a night. There's another group of people, about 20% of people with ADHD, will be able to fall asleep just fine. But an hour, hour and a half later, suddenly they're wide awake, and that's when they have their 2 to 3 hours of just being hyper alert, thoughts bouncing all around, etc. So those are the 2 things you usually hear from people with ADHD. It's currently considered that the hyperactive component of ADHD for most people gets worse at night. So that the management of it is fine-tune your stimulant medication, some Saturday or Sunday after lunch, lie down, take a nap on your stimulant medication. Show yourself you sleep just fine on a stimulant, and then you can take medication all the way through and have a dose at bedtime and sleep normally like everybody else. The medical axiom is it's always better to treat the cause of a symptom, in other words, treat the hyperactivity, rather than merely suppress the symptom, in other words, giving a sleep medication to suppress that hyperarousal. The 2 types of sleep disturbances you hear with depression are, one, the person's just sleeping all the time. They just crawl into bed and stay there. And the other one is what's called early morning awakening. And that means that in the wee hours of the morning, 2 or 3 in the morning, suddenly, not out of a dream, the person is wide awake. And by definition, they have to be awake for greater than 30 minutes. Very commonly, they're awake for the whole rest of the night. And so you'll also see it called terminal insomnia. In other words, it's insomnia at the end of sleep.
Wow, yeah.
And if you had to pick a symptom out of the 19 possible symptoms in the syndrome of depression, that early morning awakening is the one that best predicts response to antidepressant medication. So unfortunately, it's also the last one to go away, but that's actually again, when the clinician hears that and they go, "Oh, good, you're awake for the last 3 hours of the night," you'll think he's a little nuts, but he's actually saying, "I know that we're going to get a good response to medication."
Interesting. Right. So that's a classic symptom then of a depression thing. It's interesting. Okay. Some people, I think your voice was a little distorted, specifically in the response about anxiety. And people are asking if you would go back to the question of how one treats both anxiety and ADHD and whether the medications are problematic when both those conditions are coexisting.
Sure. Actually, this gives me a second crack at it. One of the things about ADHD individuals is that very commonly they will use the wrong word for feelings. Again, the fancified term is dyslexithymia, which is again Greek for the wrong word for feelings. So when somebody comes in and says, "Doc, I'm anxious," I don't take their word for it. I ask them, "Okay, forget the label. What are you using the word anxious to describe?" More often than not, what I'll get is, "I'm constantly going. I've always got 4 or 5 thoughts in my head. I have never had a moment's peace in my life. I can't sit and watch a movie. I have to constantly be doing something." Okay, that's not anxiety. That's the hyperarousal of ADHD. So basically the definition of anxiety is a baseless, apprehensive fear. In other words, I have a feeling that something awful is about to happen any moment. It's an arousal to some threat that just turns on by itself. So the first thing to do is make sure, that you got the right word for the feelings. If a person, and by the way, anxiety and anxiety disorders is probably the second most common comorbid condition with ADHD, so it's exceedingly common. Let's say, yes, the person has a baseless apprehensive fear. Then you need to treat both. They have separate treatments. And the treatment of choice for anxiety disorders is, first of all, you start with, interesting enough, one of the same medications used to treat depression, an SSRI antidepressant. Only 40% of people who take an SSRI, and this is Prozac, Celexa, Lexapro, Zoloft, all of those, only about 40% of people will get adequate symptom control with just an SSRI. The majority of people need the addition of a, quote, benzodiazepine, and that's clonazepam, Valium, that sort of thing, in order to get real complete symptom control. Right now, there are no blinded studies that show that the addition of a stimulant makes anxiety worse, which is a good and pleasant surprise to everybody. Everybody expected that it would. And again, you just have to find the right molecule and the right dose in order to really get the best response. But the two are not at all mutually exclusive.
Okay. That's so interesting. There are a number of parents who are participating in that, and the questions around children are, what are the specific, are there different symptoms for depression, anxiety, bipolar in children, and what should they be looking for in their kids? Is there any help for them in terms of distinguishing between the ADHD and behavior issues and possible depression, anxiety, bipolar?
Well, let's divide it into two groups, children under the age of 12 and adolescents ages 13 to 18, because they tend to respond differently, tend to present differently. Most kids with the presentation of depression are not necessarily going to be sad. By far the most common presentation is irritability. Everybody in the family walks on eggshells around the kid. Very irritable, has what's called affective storms. When they do launch off, it goes for hours sometimes. Almost always you'll see a very strong family history of depression or a strong family history of bipolar disorder. The statistic is that half of children who have a depression before the age of 12 will go on to have bipolar disorder. So
Wow.
it's going to be about a 50-50 split. So that's one of the things that you really need to evaluate with a prepubertal child. Is am I dealing with major depression, or is this the first episode of bipolar depression?
Okay.
What you'll see with most kids is also a social withdrawal. They'll just pull away from their friends, not want to go to school, and they want to go back in their cave because they're so irritable. And when you think about what do you find irritating out there in the world, almost always it's people. Now think about the chair that you're sitting in right now. Your chair's not irritating. It's chair-like. It always does what a chair is supposed to do. It's people who don't do what they're supposed to do and irritate us. And so that's really the source of that social withdrawal. Is just that most depressed kids are just rug-raw irritable. Adolescents typically have an atypical depression, whereas most people stop eating, they'll eat everything in sight. Where most people sleep more, an adolescent will sleep less. Where most people lose an interest in sex, they will become hypersexual. So adolescents always look very different. Adolescence is actually the most common time to have that first episode of depression. Almost everybody who will have a depression, it'll occur sometime between 16 and 19. So depression, first episode of depression, is extremely common in late high school, early college.
Yeah. So that's pretty much across the board, whether it be depression or bipolar, general depression or bipolar disorder.
Yeah. And as with just about everything, it's always a good thing to pick your parents well. All of these things are heavily genetic. So there should be, with most of these things, a fairly clear genetic line that will give you a pretty good hint about what's going on with the child or adolescent.
Okay. To the question of picking your practitioner, there are a couple of great comments here. One person, just in support of your comment that most psychiatrists don't know much about ADHD, said she asked her psychiatrist, who she likes very much and has seen for some years, whether she could have ADHD. And he said, well, can you concentrate enough to read a book? And she said, yes. And he said, well, then by definition, you don't have ADHD. So she wanted to give you that anecdote to support your comment that there are a lot of practitioners without much understanding of ADHD. And another person, John, wants to know, if my psychiatrist doesn't understand or is not a specialist in ADD, should I change to another one? If you can find one, I guess, right?
If that's it, if you can find one. The heart and soul of good medicine is the second opinion. If what you and your clinician have tried so far has not worked, or you've gotten a little bit of benefit but not a lot, or you had a little benefit and you lost it over a period of a month, and you're sort of wondering, what do we do now? Get a second opinion. Mm-hmm. A good physician is not going to be offended by that. Right. They know that this is their chance to learn something they don't know and get fresh eyes, ears, and thinking on the case. How do you find a good clinician with ADHD is the one question I get asked more than any other. What I generally tell people is go to CHAD. Mm-hmm. Children and adults with attention deficit disorder, and they're on the web at chad.org, O-R-G. Go there. These are people who are a year ahead of you in their journey to manage their ADHD. They know who's good. They also know who's not. And they can give you some guidance. Good pediatricians, good general practitioners who are accepting, competent. They're not going to make you feel like you're less than somebody else when you talk about the fact that, you've always struggled with this. So that's how I tell people, go to your local CHAD chapter. And then also Attitude, I think, has just instituted a place on the website where clinicians can be found. Is that right?
We do. We have a directory. Yeah, we're still building it, but it's so important to our readers who all are looking for practitioners that we're trying to develop a good resource because people really, really need to find good help. It's tough.
Yeah.
Yeah. For someone who asked Chad, it's Chad, CHADD, 2Ds.org. Fabulous organization. Support groups all over the country. Really important to take advantage of what Chad offers. Good directory. Also, ADDA, ADDA, the Adult Attention Deficit Organization has a directory as well. So it's hard. It's hard to find an adult psychiatrist who's familiar with ADHD. No question. Okay. This person wanting to know the comorbidity rates again, which I think you've said, but maybe it's worth repeating, of OCD, ADHD, depression, and anxiety.
If you're going in order of how prevalent they are, the most prevalent ultimately is going to be substance use disorders. Somewhere around 50 to 60% of people with untreated ADHD will fulfill the criteria for a substance use disorder in their lifetime. If you treat the ADHD, that rate goes down to the same as in the general population. The treatment of ADHD prevents further substance use. Second one is oppositional defiance disorder. Somewhere in, depending on what you read, 25 to 40% of males and about 10 to 20% of females with ADHD will also have oppositional defiant disorder. Next comes the anxiety disorders, and usually they're all lumped together as one diagnostic feature when really they're multiple things. You can either have generalized anxiety, where basically it's a person who just goes through life with their alert system, that run for your life, fight for your life system always on high alert. You can have people who try and deal with their anxiety by rituals and structure and sort of magical things. We call that OCD. Some people they'll be going along and just suddenly have bursts of anxiety and panic. We call that panic disorder. Some people will try and avoid things that they associate with being anxious, and we call that phobias. So again, it's all of those things lumped together, which call anxiety disorders, and they're the third most common. Depression is the fourth most common. So
no need. A couple of people have said, does my ADHD diagnosis mean that I inevitably will be depressed? And the answer is no. Then you're saying it's no. Yeah.
The risk is about 20%.
Okay,
lifelong.
So right. Is there a difference between men and women in terms of that we know of in terms of comorbid conditions, mood swings?
Women get depressed much more frequently than men do. At first they thought it was just women went in to see psychiatrists more easily than a guy did. Now with these very large population studies, it really turns out that women do have depression more often, and they also seem to have bipolar disorder more often. Nobody knows why.
Wow, I didn't know that.
Women tend to have oppositional defiant disorder much less than men. They tend to have substance use disorders much more infrequently than men. So there are many gender differences, and nobody has a even halfway explanation as to why. Of course, if it's happening to you, it's 100% prevalent. So
right.
it's sometimes we quote these statistics on large populations, but we deal as individuals. And so
right.
If you're depressed, then the prevalence of depression is 100%.
Exactly. Yeah. Last question on ADHD meds. For those who can't take them, here's a person who says they make me feel agitated, irritable. For another person who says my child can't take them. What's your comment about that?
The first thing to do is to recognize that 8% of people get their optimal response to stimulants at doses lower than the lowest dose manufactured. So your doctor or your kid's pediatrician may have started out on the lowest dose manufactured, and it's already too high. And you end up with nothing but side effects. So 1 in every 8 people, 8% is 1 in every 12 people. So it happens frequently. And so
rather than assume that the medication
is intolerable.
You're saying that it could well be the wrong dose.
Right. And what most people do is they will go to medications that are liquid. And so you can really go down on the dose. On the amphetamine side, that's Vyvanse, which is stable in water pretty much forever. And on the methylphenidate side, there's a new product called Quilivant. That's a suspension of methylphenidate. That's a very good stable delivery system. But again, it allows you to go to very low dosages. The other thing to remember is that we also run into stimulants out in the real world, and that if they are added on top of your ADHD medication, can get you revved up. The 6 things you have to look for are caffeine, nicotine, decongestants. Both amphetamine and methylphenidate were originally brought on the market 100 years ago as over-the-counter decongestants. Steroids, taken by injection or pill, inhaled steroids are just fine. Just about every weight loss product has, especially over-the-counter things like, can't remember the name of it right now, have a lot of stimulants in them. And the 5th one is asthma medications taken by pill or injection. Again, inhaled asthma medications are just fine. They stay put in your lungs or in your nose. So those are the 6 places where you get a stimulant added on your finely tuned ADHD medication.
Oh, so interesting. Of course, that would make sense. Yeah. I guess here's a final question. We're out of time, and it's an interesting one. Will the new frontier of biological medications specific to our genetics, do you think it will eventually help provide the correct dosage for medications for mental illnesses?
There's a big push for that right now. And it's one of those things that we are able to measure things, genes. There's 5 or 6 companies out there measuring genes that for the enzymes that metabolize various ADHD medications in general. The problem is that we really don't know what the application is yet. Mm-hmm. We really don't know if you got a high amount of the enzyme or a low amount of the enzyme. What does that mean out in the real world? So again, we can measure these with tremendous accuracy. We just don't know what it means. It's sort of like when the scanning was so popular 8 to 10 years ago. SPECT scans and stuff like that put out very pretty pictures. And to this day, nobody knows what they mean. There's no connection between the ability to do the test and get the data and applying it out in the real world. Someday, maybe. Today, not yet.
Okay, down the road. Thank you so much, Dr. Dodson. Thank you, everyone, and have a wonderful holiday season. And with that, I'm going to close. Thanks again.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.